do it to it. Hi everyone, we're just gonna give everyone like a minute to hop onto the Zoom and then we're gonna get started shortly. All right, so as people start trickling in, we're gonna get started. Welcome everybody to the Wilderness and Emergency Medicine Lecture Series being hosted here at the University of Miami. I'm sure most of you now know my name is Shilpi. Before we get started, my co-moderator Emily's here and she's gonna go over some ground rules and then we'll get right into it. So Emily.
Yeah, sorry, there's a lot of people to admit. You guys have been awesome about getting here on time. So hi Cream, I see you, so I'm gonna give you a personal shout out. But overall, hello. Hi, welcome to this wonderful series that Shilpi has been running. It's been so successful thanks to you guys. A couple of things, if you guys can all just keep your mics off, just so we don't interfere with the audio. We are recording this. You can refer to it later on our website if you're interested. And to make this as interactive as possible for our speakers and for each other, really, it would be nice to keep on your video if you're willing. If not, no worries. And also just to have an idea of where everyone's from, if you can just add the institution you're representing, that'd be great. Or if you're a medical student, you know, MS, whatever, in the institution. And I think that is it. What we're gonna do as far as questions, if you have any questions, please feel free to put them in the chat and I will ask them for you. And if there's any questions at the end, we have some that were submitted. So thank you for putting those in, guys. We'll also have those as we go through the lecture. I think that's everything.
Cool. So I do this every week. Sorry for my repeat offenders that come every week. But like I said, my name is Shilpi. I'm a second-year medical student at the University of Miami Miller School of Medicine. I'm currently on the executive boards for our Wilderness Medicine Society and our Emergency Medicine Student Associations. And I'm also on the executive board for Women in Aerospace Medicine, which is a subsection of the National Aerospace Medicine Student and Resident Organization. I'm the person that created this project and presenting this lecture series, and I'm super excited to have you guys all here. Big shout out to my awesome logistics team. Emily's here, as you just met her, helping me out. And so thank you everybody for coming. A mission, I go through this every week. I'm sure people that come every week could do this talk for me now. But for my new faces and for my speakers, I kind of like to go through this. The reason that I created this opportunity, for the obvious reason, is to expose interested students to the breadth of what wilderness and emergency medicine can be. I think wilderness medicine is badass personally, with such diversity, and I kind of wanted to create an opportunity where students could learn and engage with it well beyond the constraints of the environments in which we're surrounded by. And on a secondarily and like a deeper level, especially with this ongoing pandemic, I kind of just wanted to create something that reminded both myself and all of you why we got involved with or want to get involved with medicine in the first place. So we can like showcase the diverse spheres in which physicians can make an impact and hopefully inspire you guys to start thinking abstractly about the ways in which we can utilize our careers in healthcare and in medicine. So if you didn't know, now you do. We're all here to learn about dive medicine today, and this is the last talk of the semester. We don't have any talks for the next 2 weeks, so I hope you guys all have a Merry Christmas and New Year's, and we'll be back next year. I've been working super hard to create a super packed lineup, as you can see, for 2021. All the most up-to-date information can be found on my website, and if you haven't had a chance to look at it, I'll throw it in the chat box after this. So with that being said, the reason that we're all here, it is my pleasure to introduce Dr. Derek Covington. Dr. Derek Covington is the director of the Undersea and Hyperbaric Medicine Clinic and assistant professor in the Division of Multi-Specialty Anesthesiology at the University of Florida. He earned his MD from the University of Nevada School of Medicine Interned and completed his residency in anesthesiology and perioperative medicine at the University of Miami, Miller School of Medicine / Jackson Memorial Hospital, and completed his fellowship at the University of California, San Diego in the Department of Undersea and Hyperbaric Medicine. Dr. Covington is a member of the Undersea and Hyperbaric Medical Society and previous medical director for Dive Safety International. He was one of the 2 physicians on site for long-distance swimmer Diana Nyad during her record-breaking swim from Havana, Cuba to Key West, Florida. Dr. Covington is an experienced closed-circuit rebreather and cave diver. So with that, please join me in welcoming Dr. Covington. Hey, and I will stop sharing my screen.
Thank you, Shilpi. I appreciate it. Let's see. Hi, everyone. Thank you for having me. Let's see here. Shilpi, since you stopped sharing my screen, it looks like that PowerPoint went away. Is there, let's see here. Oh, there it is.
Yeah.
Yep, okay.
And just to reiterate for those that came a little bit later, if you're new to the series, just if you can keep your mics on mute so we can not interfere in the audio. Feel free to keep your video on, make this as interactive as possible. If you have any questions, comments, please put them in the chat and I will read them out for you. If there's anything else we can help you with, please feel free to message me or Shilpi directly. And yeah, let's get started.
All right, everyone. So today will be an introduction to undersea and hyperbaric medicine. Let's see here. And I will be periodically putting in some photography that I do underwater just to spice it up, move it along. I know it's 7 o'clock at night, so I'll try to keep you interested. This is actually my cave diving instructor, Marissa. We found this cave. It was in the middle of a swamp, kind of down in mid-Florida, and it's called the Chassahowitzka Wildlife Management Area. And you wade through about, I don't know, 50 yards of swamp. I mean, absolute black mud. And then you come to the edge of this crystal clear spring. And you could probably drive 2 tractor trailers down this spring, and it goes down to about 180 feet. And you can see it's just decorated with these beautiful limestone walls, and the sunbeams come down. It's just a magical place. We came back the very next day with all of our rebreathers, photography equipment and everything. And I got this really cool shot of Marissa looking as badass as always underwater. Let's see here. So why is undersea and hyperbaric medicine important? Why does it deserve an hour of your time? Well, first of all, it's involved in a lot of other things besides just undersea conditions. One is we use it for commercial diving. So we need to get our people who work on ships, who work on oil rigs and so forth, safely back to the surface. We need scientific divers to be able to pursue their research underwater safely. We certainly want to encourage recreational diving to be done safely. We do know that the recreational diving population is aging. They tend to be male. They tend to be overweight. And as we know, those are big cardiovascular risk factors. Hyperbaric environments also involve tunneling projects. So when they put, say, trains underneath cities, when they tunnel underneath, they actually pressurize that environment. And so the workers in those environments are actually exposed to hyperbaric conditions and may need to be decompressed on their way out. For Shilpi, we're involved in aerospace divisions and explorations as well. Duke University did some of the preliminary work on how to safely get people from the International Space Station into spacesuits. Spacesuits are such a, they expose you to such little pressure that just stepping into that spacesuit would cause decompression sickness if you didn't undergo some denitrogenation. We're certainly involved in space exploration, high altitude projects, and then of course we need to treat people with hypobaric and hyperbaric injuries. Our objectives today, we'll review some history of hyperbaric oxygen therapy. There's some really interesting history. We'll define hyperbaric oxygen therapy, as I'll abbreviate HBO. Hopefully you'll be able to understand some of the pertinent physics and physiology that underlie treatment and exposure in hyperbaric environments. This will lead us to some of the mechanisms of what's actually happening physiologically to your body when you're under pressure. We'll discuss where you're treated, which are the different types of chambers. We'll briefly go over some indications, some contraindications to hyperbaric oxygen therapy, and then some complications that you could run into. By and large, it is a pretty safe treatment, but there are things that you need to be wary of. And finally, since you guys, majority of you are in Florida, are interested in diving, at least in some way, I'd like you to become almost an expert on decompression illness by the time you leave this talk. So the history of hyperbarics has some very colorful parts to it. There are some very scared, as you can see up here, military personnel who underwent some pretty sketchy experiments that could not be done today with current IRBs. There were some animals that had some rough times in hyperbaric environments, some goats, and there was certainly some interesting equipment that were used. So I'll touch on parts of these as we go. The history of hyperbaric oxygen really began back in 1662 with a British clergyman named Henshaw. He built this thing that he called the domicilium, which he thought would help treat a multitude of both acute and chronic diseases. This domicilium was actually pressurized with organ bellows. After him, a guy by the name of Fontaine was actually a French surgeon. He actually built a pressurized mobile operating room to operate in, and that was in 1879. By 1917, the German inventors Bernard and Draeger used hyperbaric oxygen therapy to actually treat DCI in divers. In 1926, Dr. Orville Cunningham, who was a professor of anesthesia in Cleveland, Ohio, actually built something known as the Steel Ball Hospital. This was 6 stories high and 64 feet in diameter. This had 72 rooms and was 6 stories high. This could reach 3 atmospheres of pressure, which was 3 times the pressure that we're at right now. Unfortunately, this closed in 1930, 1, due to lack of some supporting evidence of what was happening in this hospital, and then 2, we needed scrap metal for World War II. Here's a picture of that Steel Ball Hospital. Pretty impressive. The next thing that really happened was in the 1930s and 40s when the Navy wanted to be able to support some of their diving missions. By the late 1950s, they had actually developed the modified Navy dive tables. These dive tables are still used largely today as backup to a lot of the computers that are used. One thing to keep in mind is that these tables were generated from fit young males. And so they figured out that these particular group of people were able to deal with these depths and these times of diving and safely return to the surface. As you can imagine, your body cannot respond or may not respond the same way as those young men, 18, 19, or early 20s may have. So your patient who's 50 or 60 coming to you and asking for a dive clearance, even though he stayed within those no decompression limits, his body may still not respond to that stress as well. So that's an important thing to remember, that these tables were generated from a young, healthy, fit diving population. Now, in 1967, the Undersea and Hyperbaric Medical Society was formed. This is an international nonprofit medical society and is the preeminent medical society today that oversees undersea medicine. They serve over 2,000 physicians, scientists, associates, and nurses from more than 30 countries in the fields of hyperbaric, undersea, and dive medicine. They also publish the peer-reviewed journal Undersea and Hyperbaric Medicine, which is one of the best resources for peer-reviewed and rigorous medicine in undersea and hyperbaric. Now, where are we today? Well, today there are 14, possibly how you read this list, 15 indications that are reimbursed from CMS. I copy and pasted this today from CMS, or the Centers for Medicare and Medicaid. We'll go through these in a little bit, but I just wanted to briefly show you where we've come from, and 15 indications right now that have good evidence, and as you will need to worry about eventually, they reimburse. Now, there are some non-covered conditions, and there are private chambers in the country and all over the world that will treat outside of those indications. As you review some of these, it may or may not be interesting that they're not, but I thought a few were interesting. One, they don't reimburse for putting patients in for senility. So no luck there. And they also don't pay you for putting organs in there and storing them in hyperbaric chambers. I oftentimes get the question whether if you stick an extremity in a hyperbaric chamber, would that have the same effect as a whole person? And that does not. And they actually even have that on the CMS website. It says topical application of oxygen. This method of administering oxygen does not meet the definition of hyperbaric oxygen therapy as stated above. Also, its clinical efficacy has not been established. Therefore, no Medicare reimbursement may be made for topical application of oxygen. This is my good friend James. James is entering a cave here in North Florida we call Little River. And at times, this crystal clear cave has outflowing water. The river that it goes into will actually come and spill above it. And when that happens, it creates this amazing blood red type of effect when you take photos towards the sun. James is using here what we call a closed circuit rebreather. This is very similar to an anesthesia machine underwater. It's completely closed. It utilizes a scrubber system similar to what we use in anesthesia with granules that pull the CO2 out. And then there's computers. You can see one here on his right wrist that actually puts in different amounts of oxygen or helium back into his breathing loop. And then of course, this is one of my favorite things. These are called DPVs, or diver propulsion vehicles. These are almost torpedoes that pull you into these caves. One, they're a ton of fun. Two, they're actually a little bit more safe for you to use because you don't have to be as metabolically active swimming into such strong flowing caves. And when you're not as metabolically active, you're not loading as much inert gas and therefore not placing yourself at more risk for decompression sickness. That being said, if that torpedo or diver propulsion vehicle is getting you back far enough into that cave, your dive may end up being longer anyway. But they are certainly a neat toy. Hyperbaric oxygen therapy. Well, what is it? It's simply the medical use of oxygen at higher than atmospheric pressures. Can anyone tell me right now what atmospheric pressure we're at?
We have from Chandler, 1 atmosphere.
Beautiful. We're at 1 atmosphere pressure, and we'll go over a few other measurements that we can atmosphere at sea level. This is the chamber at UCSD. As you can see, it's kind of a cylindrical tube or almost kind of like a submarine. And at the bottom left of the photo, you can see that's the top of a ramp. And so when we have critically injured patients at UCSD, you actually have to roll the patients up this ramp and then duck to get inside of that chamber with them, which can be challenging, especially if they're on infusions, if they're on a ventilator. Now, the chamber itself does get a little bigger because those beds will fold up towards the wall, but it still can be a little bit cramped in there, especially when you're in there for 4, 5, or 6 hours during a treatment for something like decompression sickness. If you look alongside the walls there, you can see there's some TVs that are set up that we can play movies or TV. There's a bathroom in the back, which is there, but we always encourage people not to use it. There's not a lot of privacy, and anything that you do there, everyone else will enjoy the smell. And all the way in the back there, you'll see another door. That's what we call the transfer lock. So typically I would not be inside of the chamber, but if the patient became unstable or needed something, I could be locked in on the other side of that chamber in a small little compartment. And when that compartment became the same pressure as the treatment chamber, I could open that door and address the patient. If at that point I could leave later, I could actually lock out of that as well, so I wouldn't have to stay there. So that's called a transfer lock. As we were told here, we are at 1 atmosphere of pressure. Some useful conversions for you when you're discussing pressure, both medically as well as for undersea medicine, is to know that 1 atmosphere or 1 ATM is the same as 33 feet of seawater, which is the same as 10 meters of seawater, which is 14.7 PSI, 1 bar, or 760 millimeters of mercury. I think the simplest way, especially with math and everything, is simply to stick with the 1 atmosphere. If you're diving, certainly commit to 33 feet of seawater or 10 meters. And then once you get to the medical realm, when you're worried about pressures, the millimeters of mercury is helpful as well. Now, sometimes you'll hear people say, is this gauge pressure or is this an absolute pressure? Well, you'll know it's a gauge pressure if it's actually utilizing atmospheric pressure as 0. So if you are neglecting the 1 atmosphere that we're at right now, then the pressure is relative to the atmospheric pressure. That's gauge pressure. Versus absolute pressure is the total pressure around you. This is also known as the ambient pressure. And this utilizes absolute 0 with 0. So a diver who's at 33 feet underwater is at 2 atmospheres absolute, because they have 33 feet of seawater above them. And then they also have 1 atmosphere above them, just like the person laying at the beach. So you can't forget about that 1 atmosphere even above when you're talking about absolute. Oftentimes we treat patients somewhere between 2.4 to 3 atmospheres in the hyperbaric chamber. So that is about 2.4 to 3 times the pressure that we're normally used to. Now, what is the FiO2, or the fraction of inspired oxygen of the air that we're breathing now? Does Chandler know this one?
21%.
Nailed it. So 21.
A lot of people know this one. Good job, guys.
Wonderful, wonderful. What is the ppO2, or the partial pressure of oxygen of the air that we're breathing now in atmospheres?
Got 0.21 atmospheres.
Awesome. So we simply took our total pressure around us, 1 atmosphere, times the FiO2, which is 21%, and got 0.21. So well done. And what is our ambient pressure? We already talked about. Same thing again, 1 atmosphere, 10 meters seawater, 33 feet, 14.7 psi, all that same stuff. And that'll come back as we discuss some decompression sickness. So some diving physics briefly. Boyle's law is one of the most important things to remember when you're not only diving, but then treating people with diving related injuries. And as you may remember, Boyle's law simply tells us the absolute pressure and volume of a given mass of a confined gas are inversely proportional if the temperature remains unchanged within a closed system. So again, what does this tell us? This is simply the P1 V1, or the pressure 1 volume 1, is equal to P2 V2. In other words, the pressure increases, or a pressure increase tends to lead to a decrease in volume. Now, as you can see here on the right, if you took a gas bubble, or say even a some sort of balloon, and you took it from the surface and you pulled it to 33 feet underneath, that volume would decrease by half. And that's easy because you already know at 33 feet, we're at 2 atmospheres. We have 1 atmosphere for the 33 feet of water, and we have 1 atmosphere above us. So you simply go, that volume is going to decrease by half because I increased the pressure by 2. Same would happen at 99 feet. As we sit at 99 feet under the water, we have 3 atmospheres of water above us, plus the atmosphere of the actual atmosphere above us. So that's a 4 times increase. Therefore, you would expect a 4 times decrease in volume, and that's what you would see here. Now, Boyle's law is important for middle ear squeeze when people can't equalize their ears, whether that's diving or flying or even going up in an elevator. This is important for arterial gas embolisms, as well as for breathing gas consumption and density when you're diving. And this becomes especially important for deep dives when your gas density can increase to the point where it starts impacting your actual work of breathing. Now, Boyle's law on gas densities I just mentioned here, you will see an increased gas density, which will increase your work of breathing. One of the things that we can do is actually add helium into our mixture when we start worrying about this. So during very deep dives, not only will helium help us to not load as much inert nitrogen, it will actually help us also decrease our density of our breathing gas, which decreases our work of breathing. So you'll see here on the right, as you pull a cup of air underwater, as you go deeper and deeper, the volume of that gas is going to decrease, and therefore the density of those molecules will increase. So again, at 99 feet, we have 33 feet of seawater, 33 feet of seawater, 33 feet of seawater, and then an atmosphere. So we're at 4 atmospheres. Therefore, we're at 1/4 the volume, and therefore we're at 4 times the gas density, which means that's going to make us work a little bit harder to move that gas, not only in a traditional scuba diving open circuit setup, but also in a closed circuit rebreather. Dalton's law of partial pressure. Dalton's law tells us simply the total pressure exerted by a mixture of non-reactive gases is equal to the sum of the partial pressures of the individual gases. Therefore, we know that the P total, or pressure total, is simply equal to the pressure of the first gas plus the pressure of the second gas and any other gases in that mixture. Now, Dalton's law is important because it allows us to calculate our partial pressure of nitrogen and our partial pressure of oxygen. These are important for figuring out what kind of gas that you would like to dive, especially as you go deeper and enter the realm of technical diving and decompression diving. This is also important as it tells us our partial pressure of oxygen, which, as we'll touch on later, can actually be to a level that can cause some issues that we refer to as oxygen toxicity. This is Marissa again. This is actually Marissa at a different time in front of that same cave, Little River. And again, during certain times of the year, the river will rise to the point where it almost kind of sit on top of the outflowing cave. And during those times, all of us cave divers run out there because we know that the photographic opportunities are just awesome. And so here I am looking up at Marissa, and just that really neat blood red effect looking back up towards the sun.
One of our students was asking if it's Marissa Eckert.
That is Marissa Eckert. Yep. Now, how does hyperbaric oxygen work? Well, there's a few things that it does. Certainly hyperoxygenation or increased oxygenation. We know this. This is helpful in decompression sickness, carbon monoxide poisoning. It also increases the ambient pressure around us, as we just saw. So this is actually going to decrease the size of a gas bubble, which can be helpful for things like an arterial gas embolism. If we can actually bring the size of that gas bubble down, it can flow further down the vasculature and actually go down to the point where it's not blocking as much tissue. So it can be helpful with just actually mechanical pressure against. It also causes a vasoconstriction. This is helpful for crush injuries as well as for burns when you're tending to have a lot of endothelial leak of fluid. It also causes formation of new blood vessels, or angiogenesis. This is especially important for delayed radiation injuries. Patients oftentimes with head and neck cancers will end up with a significant amount of radiation to their jaw. Unfortunately, radiation causes what we call an obliterative endarteritis. It actually destroys the blood vessels and tissues. So oftentimes these patients then develop radiation caries, and so they need their teeth extracted. Well, as these patients go get their teeth extracted, they now have a jawbone that is not healthy and is unable to actually heal those wounds from pulling the teeth because they have no support from vasculature. So one of the probably more common indications for hyperbaric oxygen therapy is osteoradionecrosis of the mandible. And this actually came from a quite famous oral maxillofacial surgeon down in Miami called Robert Marks. And it's actually called the Robert Marks protocol. And if you treat these patients with 30 sessions of hyperbaric oxygen therapy, then allow them to go get their teeth pulled, they tend to heal these wounds from pulling the teeth so much better. Now, what else does it do? It causes an increase in fibroblast proliferation. This, of course, is helpful in any sort of wounds, especially chronic wounds that tend to not get this fibroblast proliferation stage. It's actually helpful in leukocyte oxidative killing, which can be helpful in like chronic refractory osteomyelitis, so a severe infection of the bone. It's also been found to reduce lipid peroxidation. This has been helpful in the delayed effects of carbon monoxide poisoning. Lynn Weaver works out of Utah, and he's done some great work in carbon monoxide poisoning and has actually found that people who are treated not just with normobaric oxygen, but those who are treated with hyperbaric oxygen therapy tend to not get those delayed neurologic sequelae at the same rate that those who aren't treated with hyperbarics. And this is tracked back to what they believe to be a reduced lipid peroxidation. Hyperbarics is also helpful for toxic inhibition. This is useful for clostridial myonecrosis, and it's also been shown to be helpful with some antibiotics. Now, again, as I mentioned, there are 14 indications that the Centers for Medicare and Medicaid will reimburse for. So those are the things that you will typically see at 24/7 multi-place academic institutions. We really try to keep to these 14. That being said, there are some other indications that are coming down the pipeline and we'll talk about. But for now, these are the 14 that we stick to. One is carbon monoxide poisoning. 2 is clostridial myositis and myonecrosis, or gas gangrene. 3 is crush injuries, compartment syndromes, and other acute traumatic ischemias. You could even say that even as a non-traumatic ischemia, we're seeing more and more people obtaining fillers, having that filler then travel into arteries and causing acute ischemias in their face. Of course, decompression sickness, the one that I love, pretty much the reason that I went into undersea and hyperbaric medicine. Arterial insufficiencies, like the filler I mentioned. Severe anemia, so whether these patients are patients from trauma, whether these are Jehovah's Witnesses who will not accept blood transfusions, you can support somebody simply through the amount of oxygen that's dissolved in the plasma when you're under hyperbarics, that you don't even need red blood cells when you're in the hyperbaric chamber. So we can certainly help out those with severe anemia. Some intracranial abscesses can be treated here, air or gas embolisms. And as I mentioned, the classical teaching for an arterial gas embolism was what we used to call crush the bubble, that we're actually pressurizing these patients and then therefore we're reducing the volume of intravascular gas. Well, there's been more studies coming out and it makes sense physiologically that when these arterial gas embolisms happen, they are rapidly going through the vasculature. By the time that the patient hits the door to the hyperbaric chamber, it's usually hours after the insult. So really, I think these bubbles are more or less gone. There was a great New England Journal of Medicine article, and we're actually treating more of the effects of the stripping of the endothelium by that gas bubble and all the effects from that, the inflammation, the endothelial leakage. We're treating that with the hyperbarics, not so much reducing the volume of air bubbles or gas bubbles. As I mentioned, necrotizing soft tissue infections, refractory osteo, as we talked about with osteoradionecrosis of the mandible, delayed effects of radiation. This can also be true for bleeding after radiation to the bladder from prostate cancer. We certainly get calls for compromised grafts and flaps, acute thermal burn injuries, and one of the newest indications we have is an idiopathic sudden sensorineural neural hearing loss. Now, a couple of indications that you'll see coming down the pipeline: traumatic brain injury is starting to attain a lot of promising data, so TBI could be coming down. This is also in conjunction with possibly some acute stroke indications as well. There's some data to suggest that hyperbarics can help save more of that ischemic penumbra in patients with acute stroke. Now, hyperbaric oxygen therapy. Surface or normal baric oxygen may help the diver or other patients, even carbon monoxide patients, but hyperbaric oxygen therapy is the definitive treatment for these 14, or at least adjunctive treatments for those 14 indications. For some, like an arterial gas embolism, it is the definitive treatment. Now, how do we treat patients? Well, there's two types of chambers. We treat them in a monoplace, which treats one patient at a time, or we can treat them in a multiplace chamber, which can be very large. It can be the size of a room. As you can see, this picture here, this is a monoplace chamber. It's made for one patient at a time. It's a clear acrylic, usually kind of glass. You're able to see the patient the whole treatment, of course. You can usually have a TV above it for them to be entertained during the hour and a half or 2 hours. Now, these are cheaper. These are a smaller footprint for the hospital. However, you can't get to the patient. If the patient were to have a seizure or have an issue, you have to decompress that chamber before you can get to them. Also, another concern, or at least consideration, is the entire chamber here is pressurized with oxygen. As you can imagine, that has ramifications for fire risk. These are multi-place chambers. So again, we could treat multiple patients at once, or we can also treat patients who are critically injured. So we could easily roll somebody in with a ventilator, with infusions, with a critical care nurse, with the hyperbaric technician. It's easier to move and much more comfortable in these types of chambers. That being said, this chamber here is a multi-place chamber. It's beautiful. It has a flush door here, which makes bringing patients in and out so easy. This is actually at an outpatient wound clinic in Encinitas, California at UCSD. Unfortunately, all of the emergent sick patients go to the chamber that I showed you earlier. That chamber is in the basement at UCSD. It's plumbed in. It's been there forever, and it would just be so tough to get that out. So unfortunately, all the nice hardware is just used Monday through Friday, 9 to 5 for outpatient surgeries or outpatient indications. In multi-place chambers, this entire chamber is not filled with oxygen. Rather, the chamber is pressurized, usually with air, and then the patients themselves breathe either from a face mask or a hood. This obviously makes for less of a fire risk, and so it's a safety concern, and obviously logistically a little bit less oxygen as well. There is, because of that, we are still, even though that's pressurized with air, there are considerations for fire in a multi-place chamber, and the same in a monoplace. We don't allow patients to bring their phones in with lithium batteries that could get warm. We don't want them to wear high static clothing that could create an electrical discharge. We only use things that use brushless motors. So imagine ventilators or IV infusion pumps. They all need brushless motors that would never spark. We also don't like them to wear their shoes in from the street that may have oils in them. There was a pretty devastating explosion in Ocala, Florida, which is a famous horse kind of community. And they had a prized racehorse that they were putting in a chamber to help heal it from some sort of leg injury. And they forgot to take the shoes off of the horse. And the horse got scared, kicked, created a spark, and it exploded. And a few people lost their lives, and of course the horse as well. And you can see photos of just how damaging it was. It was a massive explosion. Who don't we put in a chamber? Well, really the one absolute contraindication to putting someone in a chamber is an untreated pneumothorax. If we put somebody in with an untreated pneumothorax, this could then become something worse, a worse pneumothorax, or even convert to a tension pneumothorax. There are a couple medications that we talk about. These are things that I wouldn't even worry about, but a couple medications that we at least consider if you're going into hyperbaric treatment. The main one I want you to remember is an untreated pneumothorax can't go into a chamber. That being said, if you have a chest tube, that's fine. We can put you in a hyperbaric chamber, but it cannot be an untreated pneumothorax. Relative contraindications, things that should just make you go, I just need to consider. Asthma or COPD. These are both gas trapping or obstructive type pulmonary issues. As you can imagine, as you are pressurized under hyperbaric treatment, you could actually drive gas into areas that are not well ventilated. And then as you are ascending in the chamber or depressurizing the chamber, that gas may not escape well, and you could cause some pulmonary barotrauma there, or even cause a pneumothorax upon ascending. Some other considerations, pacemaker, you always want to make sure any device that you're putting in there, whether that be a pacemaker, spinal cord stimulator, as I mentioned before, a ventilator, an infusion device, are those motors, are those batteries, have they been pressure tested? We used to not think that you could put pregnant women in, where there's some unknown effects on fetuses. It's tough to do research on pregnant women. No one wants to touch a pregnant woman. However, there are some studies out of Russia that suggest it is safe. Well, when would we put in a pregnant woman? Well, usually it needs to be some bad disease. So someone who really bad carbon monoxide poisoning, you'd probably say risk benefit, we're going to go with treating. Seizures, as we'll mention, that is a potential issue from hyperbaric oxygen therapy. It's not common, but it's something that should at least think about. High fever may place you at a higher seizure or a lower seizure, a higher risk, lower threshold. And then certainly you need to be able to equalize your middle ear. So those who struggle with equalizing their ears, that can be tough to undergo hyperbaric therapy. And we'll talk about that.
Quick question. Does that, is this contraindicated in then people that have had previous perforated ears, or is it just active issues that inhibit equalization? Because you know how sometimes if we're getting diving license, people that have had multiple perforations, they're most likely not able to get that license. So I'm wondering if that applies also to the hyperbaric treatments.
Great question. As long as that membrane is healed and it heals well, usually quite quickly, you're fine to be treated. One thing to consider is, imagine you get a patient with a very bad arterial gas embolism. These patients, usually some of the presenting symptoms are they're unconscious. These are quick neurologic insults. And so you can treat a patient who is sedated, intubated, and on the ventilator in the hyperbaric chamber. How would you think that you would equalize their ears? What would be your approach? Anyone have any ideas?
I think we're all stumped.
Abigail said open their mouth.
Good question. Some people say open their mouth. Some people say increase the PEEP on the ventilator. You know, unfortunately, none of those things work. So there's a couple options. One is you can do a tympanostomy. So you could take a spinal needle, go in, poke right through the anterior inferior quadrant, and do a tympanostomy on both sides. What else could you do? You could say, you know what, this patient is not doing well. The definitive treatment for their arterial gas embolism is hyperbaric oxygen therapy. You could just put them in the chamber. You put them in the chamber. At the end of the treatment, you're going to look in their ear and they're going to be perforated. And that middle ear cavity is going to be full with blood. The nice thing about that is for the follow-up treatment, you have a space that is no longer gas filled, so it won't hurt them. And to be honest, people rupture their eardrums all the time. And they do fine. It's not pretty when you look in their ears. You know, we had to do it a few times at UCSD. But if that's the definitive treatment, you say risk benefit, we're going to go. Great question. The main thing that you will see, and I usually tell the residents in anesthesia here at the University of Florida, they have some questions from hyperbarics on their boards. And so I'll usually tell them, one of the questions that you'll get is, what is the most common complication from hyperbaric oxygen therapy? And the first one, A, is going to be oxygen-induced seizures. That is certainly not the most common, but that is one of the more famous, one of the more, I don't even want to say dangerous because it's not, but it's something that people tend to remember. So I think they try to trip you up with that. The most common complication is simply middle ear barotrauma, and that is because patients aren't able to clear their ears. So we do things, we teach them equalization maneuvers, we give them Benadryl, we give them topical, nasal sprays, we give them something to drink, all those things, and they usually get better over time with that. Oxygen-induced seizures can happen. As I mentioned before, you want to look at your partial pressure of oxygen, and we were able to calculate that with Dalton's law. When you're diving, we typically like to keep our partial pressure of oxygen about 1.6 atmospheres, or ATM. As you can imagine, that's quite higher than what we're at right now. We're simply at 0.21. So our body can tolerate about a 10 times, range. If you think we're at about 0.21 and we can go up to 1.6, that's pretty impressive. That being said, when we treat patients in the chamber, we're pressurizing them to 2.4 or even greater. For some reason, our bodies are able to tolerate a much higher level of oxygen when we're not underwater. When we're immersed and diving, we tend to be more sensitive or more vulnerable to oxygen-induced seizures. In the chamber, if the patient had a seizure, which I may have seen one during my entire fellowship, they're quite rare. All you do is you pull that hood off of oxygen, you arouse the patient, you say, "Hi, how are you?" They say, "Great." You put the hood back on and you keep treating them. That doesn't mean that they have a seizure disorder, they don't have epilepsy, simply the brain got too excited with the amount of oxygen. Now, underwater, you can imagine there's much higher risks there. This is my buddy Aaron coming out of the water in Truck Lagoon. If Aaron had a seizure underwater, 200 feet on a World War II wreck, his regulator or hoses would pop out, he would probably die. So we are much more stringent with our exposure to the partial pressure of oxygen diving than we are in a hyperbaric chamber with someone nearby under supervision and knowing that our bodies can tolerate more. Middle ear barotrauma, what else do I want to touch on? I will show you a video later on showing where some of these experiments came from, suggesting what levels of oxygen that we can tolerate. And when we talk about oxygen toxicity, there's really two types. There's CNS oxygen toxicity, and then there's lung oxygen or pulmonary oxygen toxicity. When you're working up in the ICU and you're trying to wean the FiO2 from a patient, you're trying to avoid pulmonary oxygen toxicity. That's from a lower level of oxygen. As you can imagine, the highest we can do outside of the hyperbaric chamber is 1 atmosphere. All we can do is turn Miss Smith's ventilator to 100% oxygen, and you can't pressurize her. So she's at 1 ATM. What you don't want, though, is her to be at that for days, because we know that will harm the pulmonary parenchyma. Aaron does fine at 1 for 2 hours. That's fine, but he can't be at 1.6, 1.7, 2 underwater. That could cause CNS oxygen toxicity, which is more acute and can result in a seizure. The other complications, as I mentioned, lung barotrauma. That's why we're hesitant to have patients with pneumothorax, asthma, COPD, that sort of thing. We also see a transient myopia. We actually see a slight change in the lens of the eye that makes people's vision change a bit. Usually it's a couple weeks after they finish treatments, their vision goes the same. So I always tell them, don't change your prescription on your glasses or your contacts. This is a video of a Navy diver undergoing a CNS oxygen toxicity experiment. It's tough to watch. You'll see how vigorous the seizure is. This guy's going to place a mask on his face in a hyperbaric chamber, and he'll start breathing 100% oxygen. And then you'll see him have a violent seizure. And you will also see that they're going to place some bite blocks in his mouth
1940s film from
to
the
prevent
US
him from
Navy
biting his
shows the
tongue.
effects of breathing oxygen under pressure. As more oxygen is forced into the bloodstream, it quickly becomes toxic. The effects are debilitating and incredibly painful, and eventually, though not in this case, fatal. So at depth, where the gas has to be under pressure, the only way to stop the oxygen becoming the amount of it we breathe.
So pretty intense. Usually when we're talking about technical diving, this is a video I like to show people that I either dive with or I used to teach. You can't switch to the wrong gas at the wrong depth. You know, a few breaths of that can shift your partial pressure of oxygen high enough to where that you could have an oxygen toxicity seizure. Obviously this guy's fine. Someone in your chamber would probably be fine. Underwater, this would probably be fatal. Decompression illness. When I talk about decompression illness, this encompasses both terms, decompression sickness or DCS and arterial gas embolism. So I know that sounds similar. Decompression illness or DCI describes both decompression sickness and arterial gas embolism. So what is decompression sickness? Decompression sickness is also known as Caisson's disease or, quote, the bends. This is due to nitrogen that was dissolved into the blood and the tissues by high pressure that's forming bubbles as the ambient pressure around you is decreased. So it's inert gas coming back from the tissues into your bloodstream. Meanwhile, an arterial gas embolism is due to typically overinflation of the lungs, causing disruption of the lung parenchyma, forcing gas into the vascular system. So that's an arterial gas embolism. As you guys know in medical school, decompression sickness is important. Even Netter knew it was important. Look at that. We got a drawing from Netter. So cool. So again, this is known as Caisson's disease or the bends, and this is due to inert gas returning to the bloodstream following a reduction in ambient pressure. This could happen a scuba diver ascending too fast. This could also happen from someone leaving the International Space Station and getting into their suit. This could also happen from a Navy pilot. We treated about 5 pilots at UCSD during my fellowship because they had rapid depressurizations of their planes. They went from one pressure to another very quickly. It's the same physiology. So as a plug for undersea and hyperbaric medicine, we treat hypobaric things as well. It's the same physiology. So if you're a hyperbaricist or someone who does this fellowship, you can do aerospace things. Do you hear this, Shilpi? You can do aerospace things. You can do space stuff. It is all the same physiology. Now, where did this come from? Well, it really started with Sir Robert Boyle, who figured out decompression illness and really decompression sickness. In 1670, with that amazing hair, he noted a bubble in the eye of a viper who was placed in a vacuum. Shortly after there, a guy by the name of Trigère was a French geologist. He was actually the first person to describe decompression sickness in 2 miners in 1841. What he noted is that they had very sharp pain in their elbow and knees. And very conducive to medicine in 1850, they rubbed some alcohol over the affected area and the men were told to return to work the next day. Now, one of the neat things about the Brooklyn Bridge is it was really taught us a lot about decompression sickness. So Dr. Andrew Smith was actually the supervising physician during the construction of the Brooklyn Bridge. And in 1873, he was the first one who used the terms caisson disease, compressed gas illness, or the bends. And he described 110 cases of DCS during the construction of this bridge. Now, a caisson is a large watertight chamber that's open at the bottom, so the worker down here, and it's pressurized. This allows them to actually build the stilts or the supporting structures of the bridge underwater by keeping them dry. So they put this enclosed watertight chamber that goes from the surface of the water all the way down to the bedrock. The workers then climb down into these structures and dig out the bottom of the bedrock and put in these pilings or supporting structures for the bridge. As you can imagine, they have to pressurize these caissons to prevent water from coming into them. Well, unfortunately, they had no idea about decompression sickness. So here's Derek down here swinging away a pickaxe for 10 hours, heavily exerting himself under pressure, and then coming straight up to the surface without any decompression. Well, sure enough, they had amazing cases of decompression. They were so bad that the guys would come up from working and they would lean forward and have kind of this odd shuffle because they were under so much joint pain from this decompression. At that time, there was a fashionable way for women to walk or to dress, and it was called the Grecian bend. Dr. Andrew Smith thought that the guys getting up from the caissons were leaning forward and walking so funny that it reminded him of the ladies who did the Grecian bend, and that's where the term comes from, the bends. Now, decompression sickness has 3 types. We have a type 1, which is typically the most benign. This involves musculoskeletal systems, the skin, lymphatic tissue, and usually accompanying fatigue. People will just tell you, I'm so tired. Type 2, this starts to get a little more serious. We're involving the neurologic symptoms, cardiopulmonary, audiovestibular, and potentially even kind of shock symptoms will show up. For some reason, the venous outflow of the lumbar spine tends to be a very sensitive area to where inert gas likes to go. Unfortunately, as you can imagine, if you're impeding the outflow of the lumbar spine, you're going to get symptoms like paralysis, inability to either urinate or defecate, and those are signs that are heavily reported in patients with type 2 decompression sickness. So serious stuff. Type 3 can be described sometimes, and this is a syndrome that has progressed to a spinal deficit that may even be refractory to recompression. This is cutis marmorata. This is a classic skin rash that is associated with decompression sickness. You can note kind of the irregular borders. It's very red, it's blotchy. You can even see the venous engorgement of the superficial veins there. This is classic cutis marmorata. And I know that, and I hope it's not too much information, but that's actually my belly. That was during residency, and I did a wreck dive off the coast of Pompano, and it was a decompression dive. I probably did 30 minutes of decompression. I did the right decompression. I didn't go, outside of my tables or my computer. I got to Publix. I was going to get some things for fish tacos. We had got some lionfish. We'd speared them off a deep wreck. And in the aisle of produce, my belly just started itching. It was about an hour and a half after, and I lifted up my shirt and I was like, oh my gosh. So right there in Publix, my buddy took a good photo of me and my belly there. This is my second case of cutis marmorata. This happened here after a cave dive. You can see here again, it's blotchy, it's red, and it also has this nice venous engorgement. Unfortunately for me, we know that inert gas tends to like fatty areas. So you can see that it's gone right to my belly, both in the front and the side, which is classic findings. Both of these, I got on surface oxygen. I just breathed some oxygen that I have at home, and it went away quickly. That being said, the better treatment, they say docs, the worst patients, you really should go in and get treated. This is a fatal case of decompression sickness. As you can see, this cutis marmorata is pretty extensive. This is from, I want to say, the 1980s at UCSD. Dr. Newman there saw this patient and documented this, and he's a famous dive medicine doctor out there. So decompression sickness is serious. There certainly can be. Now, what's the treatment for decompression sickness? Well, one is 100% oxygen. Best thing you can do right away, put the patient on oxygen. Right now, your blood needs oxygen, and it needs to get rid of that nitrogen. By creating a concentration gradient of 100% oxygen, you're actually going to encourage that nitrogen to come out of solution and get out of the body sooner. However, the treatment of choice is recompression or hyperbaric oxygen therapy. It is best if it's within a few hours, but there is no real time that we won't put you in. But it is best to do same day, next day, and sooner the better for sure. There are different treatment protocols. One of the most famous ones is called the treatment table 6. A treatment table 6 comes from the Navy. It can last anywhere from 3.5 to 5 or 6 hours. Sometimes you do need follow-up treatments, and some 1, 2, or 3. Some very severe cases, some have been even documented 15 or 20 treatments. I love this when Chuck Norris dives the pretty good. Discussing decompression theory. I give a lecture here to some of the students here who are undergoing some more advanced diving classes, and we talk about decompression theory. And one of the things I talk about is it really is theory. As I mentioned before, those dive tables came from 18 to probably 23-year-old healthy males. Those were empirically derived data that probably do not translate to all of your patients that you see. Probably almost none of my patients that I see are in that age group and are that healthy and fit. So again, it is a theory. And Carl Huggins actually is on, he lives on Catalina Island and helps run the chamber out there for USC, University of Southern California. He did a lot of work with some initial development of dive computers. And very smart guy. And I love this quote that he talks about how not exact decompression theory is. So he says, decompression is an area where you discover that the more you learn, the more you know that you really don't know what is going on. For behind the black and white exactness of table entries, the second-by-second countdowns of dive computers, and beneath the mathematical purity of decompression models lurks a dark and mysterious physiological jungle that has barely been explored. And that was in 1992. There was still a lot of stuff we don't know. That being said, we are doing some amazing exposures now and bringing people back pretty healthy. There is a colleague of mine named Andrew Pitkin. I highly recommend, if you like cave diving videos, take a look. He regularly does 12, 14, 18, 20-hour dives here in Florida, down to depths of over 400 feet. And he comes out walking and goes to work on Monday, you know, so it's pretty amazing. Even though we don't understand everything physiologically, we are able to create a pretty safe record, especially for people who aren't doing decompression stuff.
We're coming up at 8, so do you think we can wrap up the next couple of minutes so we can have time for questions?
I have 2 slides here. I briefly touched on what's going on here. Does anyone want to tell me what's odd about this chest X-ray?
Anyone? Heart on wrong side, says Monica.
Maybe. What else about the heart? It looks
Lung is
like
collapsed, says Daniela.
the heart's almost the same kind of, what do you want to say, opacity is almost like the lung field. What would that tell you?
That there's air in the heart.
Air in the heart. This is a patient who died from a massive arterial gas embolism. The heart is completely full of air. Look at that. Some of the huge vessels on cross section here, full of air. If you look up here, the axillary artery, full of air. This is a massive arterial gas embolism. How about this one? Same thing. Absolutely amazing. So one more plug for hyperbarics. It's the best. I briefly want to say it's a 1-year fellowship. It does require a board certification in a primary specialty, anesthesia, which is the best. You could do emergency medicine, which is okay. Surgery or medicine, all those go into Undersea and Hyperbaric medicine fine. You can get board certified either through the American Board of Emergency Medicine, or if you're anything else, as I was, American Board of Preventive Medicine. There are a limited number of programs and spots, 12, 15, not that it's super competitive, it's just very much a niche thing. Duke, UCSD, and LSU are probably some of the top spots. Tips for medical schools, some of those who are younger, always eat, even if you're not hungry, because it may be 12 hours before you get a chance to eat again. Get your hands dirty and raise them. Ask any question you want, do every procedure. You're paying good money to do so, and this is the time to be terrible at something. Pursue a specialty for you and only you. There are poor surgeons and very rich psychiatrists out there. And remember, being a physician is still a middle-class job. Live below your means for as long as possible. Lifestyle creep is real. I work with people who are still living paycheck to paycheck, and you shouldn't be as a doctor. When someone tells you to leave, do not question that. Say thank you very much and leave. Breathe. It can be life or death, but you need to do this for a lot of years, so don't take it too personal. This is my buddy Ryan diving in one of my favorite caves here in North Florida. Once you squeeze through this little pocket, the cave opens up to this massive, huge thing, and it's beautiful. Thank you for having me. I appreciate it. Any questions?
Yay, thank you so much. That was an awesome talk. We're going to open up the floor for questions. Emily is going to help moderate that. But thank you so much. That was truly inspirational.
That was a great lecture. I feel like I need to watch it again just to understand it completely. And it could easily have gone for another couple of hours, but that was amazing. So I guess going off of some of the wonderful medical student advice, we'll just ask a couple of these questions and then go back to some of the more specific questions that you guys have had. But one of the first ones was, how common is it for an anesthesiologist to complete a fellowship that is considered a traditional EM-led field, like dive medicine? And then do you have any advice for med students interested in both anesthesia and certain aspects of EM subspecialties?
Dive medicine and undersea and hyperbaric medicine is entered by all sorts of people. Retired surgeons go into it, family medicine docs go into it, internal medicine. I would say emergency medicine docs may be the most common, but only by a little bit. So any field that you pretty much want to go into, barring psychiatry or maybe radiation oncology, you can do it. The only thing is, I would say, I'm biased, anesthesiologists, you definitely are able to care for some of the more critically injured people more easily. The emergency med docs as well, you're used to kind of treating big time changes in blood pressure, managing airways, that sort of thing, but it can be done. There was a family med doc who came a year behind me at UCSD and did just fine. For someone considering what anesthesia and emergency medicine, that was the other.
Yes.
Two great fields. Honestly, my co-fellow at UCSD was Tony Belaski. He was emergency medicine doc in the Navy. I will tell you, it was interesting spending a year in a different department. I will tell you this, emergency med docs work really hard. They work really, really hard. I think I work hard some days, but I will tell you, I don't miss lunch normally, and seeing my cutest marmorato, I probably should once in a while, but I always usually have a chance to eat. I can go to the restroom. My buddy Tony would tell me stories that, Derek, I didn't eat. I got, even though I had the 12-hour shift, I got 2 hours of charts. I don't have that, but it's still a great field. I think it's something that you meet interesting people that like medicine, but also have a life outside. So two great fields, absolutely.
What is lunch is what I have to ask that a question follow up, but I'm having a combination of questions here from Kareem and Chandler. What percentage of patients who go to the chamber are due to decompression sickness versus other causes at your institution or what you've seen? And then from Chandler, how often have you seen HBO used for the treatment of cerebral palsy? And have you seen this in your experience?
Great question. So decompression sickness is something that at a busy facility, you'd probably evaluate 4 to 5 people in the ED for a month. And we used to say press or treat half of those. So we'd probably treat 2 or 3 a month at UCSD. The things that pay the bills for the chamber Monday through Friday are those other outpatient things. So diabetic foot ulcers, delayed effects of radiation, hearing loss, all those other indications that are not emergent. Those are the things that pay the bills and help keep the chamber open. A lot of those require 10, 20, or 30 treatments, and you can treat multiple patients in those chambers. So that's why, unfortunately, a lot of places have gotten to the point where all they want to do is outpatient Monday through Friday, non-emergent indications. They want to make the money, but they don't want to be on call, and they don't want to staff those type of cases. What was this follow-up question on there?
Cerebral palsy, I believe.
Cerebral palsy is not an accepted indication for hyperbarics. That being said, you will find things online that people say that their child, brother, sister, mom got better with it. Maybe they did. I don't know. We don't have enough robust literature saying that it will help, and it's not reimbursed for. So we really won't treat it. That being said, you will see private chambers who people don't, if you have the money, they will treat you. They will put you in after your ACL to get repaired. They will put you in for cerebral palsy, autism, all sorts of things. So I have never treated someone with cerebral palsy in a chamber.
Awesome. And another question from Abigail. If you needed to access a patient that was in a monoplace or in the multiplace with a second door option, how long would it take to equalize and reach that patient?
So it kind of depends on you. And it's funny, I went to UCSD being a very avid diver, and for some reason, I find it tougher to equalize my ears in the chamber than underwater. I don't know why, but as fast as you can equalize your ears is as fast as that they'll pressurize that transfer lock. As you're being pressurized in that transfer lock, you have a headset on, and you are visually seeing the person who's pressurizing the chamber. And you are sitting there like this with an okay sign, and you're equalizing. The minute that you feel like you can't equalize, you wave off and they stop pressurizing the chamber. So you're usually able to do a minute. They go, Dr. Covington, we need you in there. You jump in, headset on, and as fast as you can go, they can get you into the chamber. So at that point, you hope that you don't run into issues with equalization, but usually you can get in. There's usually a medication lock as well. It's usually, the size of a shoebox, and that way you can lock in medications if you needed. And those are instantaneously pressurized, and then the door can open. We also called that the coffee lock. You'd be in the chamber and you'd be like, hey, anyway, you could throw a coffee in here, and they'd pressurize it and put it in for you.
Wonderful. And then I think we're going to do one more question, you guys, but we will send the rest of the questions to see if there's anything else that we can have them answered, and then we'll email them to you as well, and it'll be available. Let's see, last one. Where was my question? So Nicholas was asking, what are your thoughts for someone who ascends to the surface who didn't complete their decompression stops, getting back in the water to complete the decompression stops for a tech diver who needs decompression?
It's a great question. So that's called in-water recompression. I'm guessing that's coming from a technical diver. That
Sounds
is
like
a
it.
very, what was that?
It definitely sounds like it. I'm not familiar.
I am, yeah.
Yeah. So IWR, in-water recompression, is definitely a controversial topic. It is, I think, something that you need to discuss beforehand or think about before you dive. Did you miss 5 minutes of decompression or did you miss an hour? If you missed 5 minutes of decompression, I probably wouldn't get back in the water. I'd probably say, just surface. The other consideration is, where are you? Are you in rough seas? Is it cold? What's your support staff? How much gas do you have? I will tell you, I do some diving and some supervision of the guys doing some of the exploration down with KUR, or Carson Underwater Research. And these guys are doing 15-hour cave dives at 300 feet. And we talk about, gosh, what would we do if we had some decompression or someone missed? And in that situation where we have 15 support divers, everyone's a tech diver, we have rebreathers, we have oxygen, we have a controlled cave environment, sometimes we have underwater habitats, we think that we'd probably do in-water recompression because we have support divers, a controlled environment, all those sorts of things. So great question. There was a good review by Simon Mitchell that published some information on in-water recompression. If you search in-water recompression, Simon Mitchell, you'll find some good stuff. But it's a great topic. It's a very, very interesting topic, especially when you pair that with a dwindling number of available chambers for us to get treated with people who are still doing aggressive dives. It puts us in a spot that we have to consider it, unfortunately. When you go to international dive meetings, no one has this issue. All the Americans go, what do you guys do for, divers? We have, less and less chambers. And they go, well, why do you guys allow people to open up hyperbaric treatment facilities and not share the burden of call and treat people? In other countries, they say, sure, Derek, you want to open up Derek Hyperbarics? You need to help share the call then for emergencies. Otherwise, they won't credential you. Here, we credential everybody and allow them to make money from the community, but we don't make them treat us for emergent things like carbon monoxide poisoning, gas embolisms, and decompression sickness. So that's kind of on us, by not holding people accountable.
Wonderful. Thank you so much. And other questions from Samuel and Kelsey? They're great questions. We will get the answers to you through email just because we want to wrap this up today. But thank you so much, everyone. Shelby?
Yeah, thank you everyone for coming down. We made a note of all the questions that you guys asked, and I will bother Dr. Covington to hopefully get some of the answers for you guys. Dr. Covington, that was an awesome talk. Thank you so much for taking time out of your busy day to give it to us. I know I'm going to speak on behalf of everybody that was super great and definitely reminds us kind of why we're going into medicine, and that medicine is pretty fucking cool. And so, yeah, everybody, we're going to wrap it up here. Thank you so much for coming. I really appreciate it. Have an awesome, awesome holiday. Take a break, take a breather, eat as many lunches as you possibly can. And see you guys in 2021.
Happy holidays, everyone. Thank you.
Thanks, everyone.
Thank you.